Amazing. Okay, thank you so much. Well, again, I just want to say a huge thank you to everybody for being here today, tonight, this afternoon. I know that we're coming from all across the country, so I appreciate everybody coming for this webinar that we're putting on. So to introduce myself a little bit, my name is Jacqueline Phillips. I'm the Resource Center Director for the Vancouver and Lower Mainland area at the Huntington Society of Canada. Before we get started here with this presentation, I just wanted to give a bit of information around who we are as an organization, in case you're not familiar, as well as what our family services team does, which is the team that I'm a part of. I also want to say that I'm super excited to have Jasmine here tonight, who I'll be introducing shortly. But this is a really exciting presentation for me personally, because I think this is a really important topic to discuss in the Huntington's world. It's an area where I'm referring a lot of clients to, and I think that there's a lot of new knowledge that's starting to come up around the benefits of starting early with this type of intervention, integrating a speech pathologist into your care. So I'm really excited to have Jasmine here to explain that much further, because she's the expert and also a wonderful person that I refer many clients to. So I feel very lucky that she's going to be here presenting for us today. Okay, so for starters, the Huntington Society of Canada. So who are we? We're a not-for-profit charitable national organization. So what we do is we support families across Canada and anyone who's impacted by Huntington's disease. So this could be someone who's diagnosed, this could be someone who's at risk, this could be a caregiver or family member, or just simply anyone within the community who is impacted by the disease or needing some sort of support in that area. So our mission is to improve the quality of life for those affected by Huntington's disease. And then you can see here on the PowerPoint that we just kind of have a streamlined chart of how our organization looks staff-wise. So as mentioned, our family services program, it spreads across Canada. So the only province that we don't serve is Quebec, but if you want to be connected to services that support those with Huntington's disease in that province, we can certainly connect you. There is support there. So at our organization, we have our national director and 2 team leads. We've got our national family services educator, our national child and youth practitioner, and then the 16 resource center directors that again are spread across Canada. So our family services program, what do we do? So again, we support families or anyone impacted by Huntington's disease with really anything Huntington's related, is what I like to say. So some of those things are direct support for individuals and families. We run local, regional, and national support groups. We provide information, education, referrals, and advice on on how to connect to outside resources. We've got short-term counseling, we do individual advocacy, we support chapters, and then we also participate in HD clinics. So we are part of the medical multidisciplinary care team. So we will collaborate with your psychiatrist, with neurologists, again, with the HD clinic that's located in our area. So for my area, because I'm serving the Vancouver and Lower Mainland area, I'm connected to the UBC HD clinic that some of you may be familiar with. So I work very closely with the medical team there in making sure that you're getting the proper support, and they're referring you out to us and the family services team for anything that we might be able to support you with. As well, we're part of the community multidisciplinary care team. So again, we're able to support and educate and be part of the process with anything that might be community related. So whether that's looking at topics around MAID, whether it's getting financial support, you're looking for housing, potentially there may be child and family services support or palliative care, anything that's out in the community, we can collaborate with those individuals and professionals and be able to be part of that care plan. And then finally, if you want to contact a family services team member, of course, you can head over to our website as well. We've made it super easy here for you. So you can just scan this QR code with your phone and we'll be able to get you completing a short contact form and then connected to the RCD that's in your area. Okay, so now for the important stuff. As I mentioned earlier, Jasmine is here to talk all about the speech pathology world and how speech pathology language world and how it's going to benefit HD and when you should start getting that support. So Jasmine, a little bit about her. Jasmine Claude, she's a certified and registered speech language pathologist with a clinical focus in neurological movement disorders, including Huntington's disease. So she's played a pivotal role establishing the first full-time public speech language pathologist program for neurological movement disorders in her province of BC. And she's located at a specialized neurology clinic in Victoria. Jasmine is also the founder of Speak Strong, a private SLP clinic designed specifically for people living with neurological movement conditions. She is a clinical educator at the University of British Columbia, and Jasmine serves on the committee of her provincial Speech Language Pathologist Association and is a clinical advisor for research exploring how artificial intelligence can improve quality of life in progressive diseases. So Jasmine's contributions in her field and community have been recognized with the prestigious Celebration of Excellence Award from her health authority. So again, very exciting. Some really cool, strong experience in there in this introduction. And then, like I mentioned, my own personal experience of referring clients over to Jasmine. I've heard nothing but amazing things around her knowledge and expertise and just how much she's done for the Huntington's community in regards to this topic. So again, very excited. And without further ado, I'm going to pass it over to Jasmine.
Oh, thank you so much. That was such a lovely introduction. I am so excited to be here. And thank you everybody who's taken time out of your day to join us. I also have slides that I'm going to share. So I'm going to go ahead and do that right now. So bear with me one moment here. I'm going to make sure I do it right. We practiced earlier, so I'm feeling confident, but just in case, can somebody let me know if you see these slides here?
Yes, it is up, Jasmine.
Perfect. Thank you very much. So again, we're here to talk about HD and speech language pathology, specifically the importance of early and ongoing support. So I want to start with a big thank you to the Huntington Society of Canada. They have done so much incredible work bringing education, resources, and opportunities to the community and to the clinical world. So I'm very grateful to be here talking about speech language pathology, and they've been fantastic to work with. So thank you so much for making this come to life for us. So I'm going to skip over the introduction of myself. Jacqueline did an amazing job doing this, but I do have a few disclosures. So of course, I do have a private practice called Speak Strong that offers virtual services specialized in movement disorders to people living in British Columbia. I'm also employed by Island Health at the Victoria Parkinson and Movement Disorders Clinic. And then I have various partnerships and affiliations with different societies and nonprofit organizations, but I don't have any financial interests or sponsorships from any mentioned products today. So I do, of course, have another disclosure that this presentation is for information purposes only. So we are not intending to replace or to substitute professional medical advice, diagnosis, or treatment. I always encourage you to seek the advice of your qualified health team. That being said, I'm happy to answer general questions, especially ones that might apply to the broader community of people living with HD. So how are we going to get through the content today? I'm going to first introduce speech language pathology, or SLP, and then we're going to talk about how SLP integrates with HD and our scope of practice helping patients living with this diagnosis. Specifically, we're going to go into some of the assessment and treatment options, as well as some strategies that hopefully you can walk away using right away. And then, of course, we're going to save time at the end for that Q&A. So we're going to start off with a little poll, and I want to know from you attending today, do you know what a speech pathologist is? You can say, yes, I do, or I know a little bit, maybe I'm familiar, but not sure. Or number 3, I'm totally unfamiliar, but I'm here to learn. So I'm going to give us a moment to answer that poll. Feel free to let us know where you're at.
And for some of you, the poll might have popped up on your screen. For others, you can find it in the chat there. And Jasmine, are you able to see the poll?
I'm not, no.
Okay, no worries. I wasn't sure if it popped up for you.
Oh, you know what? Actually, I just have to click a few buttons. Yes, okay, I can see the poll. I see some people know a little bit, and some people say, yes, I do know speech pathology. Oh, and then someone doesn't have access to the poll.
And if you don't have access to the poll, because it looks like, yeah, some people don't, feel free to also write your answer in the chat there, since we do have the chat available.
Good, good. Well, this is reassuring to know that some of us do have at least some familiarity with speech pathology. That being said, if you're a person who doesn't or you feel unfamiliar, you are still in the right place. I'm going to start right from the beginning so we're all on the same page with what is speech language pathology. So we are health professionals who identify, diagnose, and treat both communication and swallowing disorders. And we do this across the lifespan. Now, a lot of people are surprised to hear that we work with swallowing, but when we're talking, the muscles we're moving to move our face, to articulate, our breathing, those are all the same muscles we use to chew and swallow. So as a speech pathologist, my job is to help both functions. I do also help some of the thinking behind communication, things like finding our words, organizing our thoughts and sentences. And we're going to get into all of that a little bit deeper soon. Now, something important to know is that speech pathologists work with a variety of populations. So some of us work in the pediatric world with children, babies, or in schools. And some of us work in hospitals. For example, I have colleagues who work with patients after they've had a stroke, or patients who've had throat or oral cancer and needed parts of their anatomy removed. Some of us also work in the corporate world, the tech world. There's a huge range. So if you are looking for a speech language pathologist, it is vital that you find someone who either has experience or training specifically in Huntington disease or movement disorders, okay? Now, when it comes to HD, I consider 5 different categories that we help with. The first is swallowing. So taking food safely and comfortably, as well as liquid, pills, and saliva. And then speech and voice, which is the actual movements of our face, our tongue, our throat, our breathing muscles to help say the words we want. And then there's cognitive communication. And that's the bit going on behind the scenes in the brain. So coming up with the words we want to say, understanding what the other person maybe said, and organizing our thoughts into coherent sentences. The other thing we help with is saliva management. So in HD, it can be common to have too much or too little saliva. Now, there are some strategies we can do, and a speech pathologist is a great person to offer you some ideas or point you in the right direction. And then, of course, patient education. So providing you with information about where you are, red flags to look out for, ways your care partners could get involved, all sorts of things. So here's another little audience participation, another little poll. I'd love to hear from you. So what do you think? When can a speech language pathologist support someone living with HD? Is it 1, at time of diagnosis? 2, a few years after diagnosis? 3, late stage management, or 4, at any point in your journey with HD? So I'll give a moment for people to answer that one. All right, great. You are all on top of it. I can already see some answers coming in. Good. Excellent answers, everybody. So the true answer I consider is number 4, at any point. I like to tell people it is never too early and it is also never too late. A speech pathologist can provide that support. I have some patients where all we're doing is getting baseline measures, even if they don't really have bothersome symptoms, just so we can track progression over time. So the Huntington Society of Canada has some fantastic resources. One of them is their physician's guide. And in their guide, they actually point to the fact that in HD, some treatment goals are to reduce the burden of symptoms, maximize your function, and also optimize your quality of life. The good news is allied health professionals like speech language pathologists can play a big role here, whether that's counseling and information, some recommendations, or assessing and addressing those safety concerns. So what does SLP intervention look like? What can you expect? Well, it depends on a few things. It depends on your goals and priorities. So what's important to you in terms of your social life, communicating, and how you like to eat or drink, as well as your needs, what keeps you safe. And then, of course, the resources available. So again, for some of my patients, it's just early getting baseline measures and providing education. For some of my patients, we're looking at strategies, things they can start trying to build up some of that independence. Other patients are looking for more treatment, things like exercises they can do, whether that's one-on-one or in groups. I also have some patients who prefer a follow-up style where maybe we just check in every 6 months, and that's okay too. A speech pathologist can also be a great person to see whether other referrals might be needed, and we can provide services in person or virtually. Okay, so even if you live in a remote area or there aren't many speech pathologists living where you do, you can get virtual services online. So let's get started with communication. Now, when I say communication, I'm actually talking about 3 things. That's our speech, our language, and our cognition. Speech is the actual movement of muscles, the articulation of our face, the voice in our throat, breathing of our lungs, so the movement of our body. Language is more the ability to understand others, express ourselves, and find the words to describe what we're trying to say. And then cognition is more so the memory, attention, and problem-solving skills needed to keep up in a conversation. Now, we really need all 3, and a speech pathologist can help identify if any one particular area needs help or if all of them do, because everybody's different. When it comes to HD, some of the most common things we might see are involuntary movements that impact our ability to speak, right? So just like we might get involuntary movements in the body, that includes of our face, right? So articulation can change. We might have difficulty coordinating our breathing with when we want to talk. So we have pauses or extensions when we're speaking that might sound unnatural to other people. Maybe our voice has changed. We might sound raspy or harsh. And then, of course, our emotion in our face can change. And so care partners might notice that the way your face looks doesn't actually describe how you feel on the inside anymore. And that's all okay. That's part of the HD, and we can work through that. Now, the medical word for changes in our speech is dysarthria. You do not need to memorize this word at all. I just have it up on the screen so that if you hear your doctor or your speech pathologist say this, you have a sense of, okay, we're talking about difficulty speaking. Now, I have a little video just to break up the presentation a bit that I love. I show this to patients all the time because I think it's such a good way to understand the anatomy from the inside. So when we're talking, there are so many muscles and things that need to move in perfect coordination with timing and strength for us to talk. And so this video is of somebody singing in an MRI so that you can actually see what's going on. So I'm going to hit play and you should be able to hear this through your speakers. Here we go.
Singing in the MRI. Singing in the MRI. Singing in the MRI. Singing in the MRI. Hi, my name's Tyler Ross. I'm a singer, voice teacher, and vocalist in New York City. And using the magic of MRI technology, I want to show you what it looks like inside my head and neck while I'm singing. But first, let me warm up on a lip trill. How about a raspberry? Weird, right? Want to see that on an ooh vowel? Ooh. Now, before I go any further, let's try to figure out what it is we're actually seeing here. Let's go back inside and see if we can identify some of the features of the vocal tract. Lips, tongue. This difficult to control piece of anatomy is called the velum or the soft palate, but you can think of it as the nose gate. It opens and closes, controlling the flow of air and sound up into the nasal cavity. In most people, the velum is opening and closing constantly when we speak and sing, and we're barely even aware of it. Down here, we have the larynx, which houses the vocal folds. Now let's see what happens inside the vocal tract when we sing with contrasting singing strategies. I'm going to sing the end of Nessun Dorma, Puccini's great aria. I'm going to sing it in 4 different vocal styles. The first will be in a light mix. The second, in a forward-facing Broadway sound. The third, in a back and down operatic sound. And the fourth, in a style that will make Puccini roll in his grave, in a rock style. All'alba vincerò, vincerò, vincerò. All'alba vincerò, vincerò, vincerò. All'alba vincerò, vincerò, vincerò. All'alba vincerò, vincerò, vincerò. What you're looking at here are comparative images of the same vowel being sung at the same moment in each vocal style. This is a frozen moment showing my vocal tract singing the E vowel on a high B flat. Now, for those of you who are interested, that's the E, as in vincero. Let's listen to it on a loop. Take a moment to see for yourself how the anatomical features of the vocal tract that we can see here align differently in each style. How is the tongue positioned differently? How about the velum? The mouth opening? How about the height of the larynx?
Oh, wow. Pretty cool, hey? I like to bring that up because to me, when I see that, it really shows how tiny and how big some of the movements of our face and our throat are just to make different speech sounds. So if we have HD and we're already having trouble controlling our body, it makes sense that that can change our speech, right? Any change of the body is going to have that how we can move our face accurately and how we can control all that different anatomy. So if we are having those changes, it's important to know that it can be impacted by a variety of symptoms in HD. Because of that, different treatments will be effective at different times and for different people. Some of my patients were looking at ways to rehab the voice, strategies they can use to sound different or to sound the way that they want to. Maybe we're using supportive strategies, especially involving family or care partners, or we're looking at ways to keep the person communicating safely, right? So could you talk to a stranger if you needed help? Could you call 911 and be understood if you had to? And then, of course, social fulfillment and quality of life. Where does communicating matter to you? With who and how can we improve that? Now, in some cases, if we're looking for ways to supplement or replace our speech, there's something called augmentative and alternative communication, or AAC for short. So if speech is challenging, then we can find a more accessible way to communicate. That can be either adding something to our speech or using a different method instead of speech. And we do this all the time without realizing it. When we use the microphone, for example, we are augmenting our speech. I'm still talking, but I'm using a device to increase my volume so I can be better understood. When I'm writing something down or typing something out, I'm still communicating, but I've found a way to communicate instead of using my voice. All right. And when we have HD, that's an opportunity to see if any of these strategies can help us as well. So I like us to think of teachers, for example. Teachers use AAC all day, every day, to communicate quite complex topics, and in many ways to help them communicate those complex topics. So whether that's pictures in the classroom, reading or writing, using physical materials and demonstrations, or technology and devices, gesturing to help get attention, there's lots of ways we augment our speech. Even the fact that I use my hands a lot when I talk, that's me supplementing my speech to show you when I'm emphasizing certain topics and things like that. When it comes to AAC and HD, there's so many options. We can think of things like communication boards where we can point, technology like apps that can help talk for us, and more. But even in emergency situations, it can be good to have something called a wallet card. All right, so a wallet card is a backup. It's if you're having trouble communicating, but you need to get a message out urgently. For example, if you're in an emergency room or something like that. Now, I make these freely accessible on speakstrong.ca. You can download them. They're already sized and colored, so you can just print them and put them in your wallet. And there's different versions. So there's an alphabet board in case you want to spell out something, a quick needs board in case there's a phrase you want to use, a little list of your emergency contact name and allergies, or if you are in an emergency, who's your contact person. All right. So these are things where we might use them. And if we do use them, they can change over time. So an AA strategy one of my patients likes now, they might no longer like in a few years, and they might want to switch to something else, and that's okay. One little trick is to have other people try it as well. So if you found an app, for example, that talks for you or that you can spell out what you want to say, get friends and family to try communicating with it as well so they get a sense of what you're going through. Because learning curves are normal. And I bring this up because a lot of these strategies are something that is best to try before you need it, right? We know that in HD, things like stress and anxiety can make our symptoms worse. So if we're trying to learn a way to communicate better and we're at a point where we need it and we're anxious, it could be harder to learn that skill. Whereas if we start finding ways to supplement our speech early on, then it's easier to implement down the road. Now, what about language and cognition? So the thinking, the behind the scenes skills for us to communicate. Well, in HD, some of the most common symptoms are things like initiating conversation less, difficulty organizing our thoughts or ideas. Maybe we have difficulty with topic changes, or we get distracted easily in conversations. Maybe there's some forgetfulness or inattention. Again, for all of these things, there are strategies and options available. So I'm going to go through a few here just so you can walk away with some ideas right away. So if you are a person living with HD, something you should know is that as a speech pathologist, I can confirm most people are not great communicators, whether they have HD or not. So we need to find ways to help enhance our communication, or at least reduce the barriers around us. So there might be variables that we can adjust. So when I'm talking to somebody, it's best if I can see them, if I can hear them well, so less background noise, reduce distance between us, that we're both focused, we're not multitasking, doing dishes, texting, and that the situation stress is managed. So talking across the home about something and yelling, it might show urgency, but it's not a great way to communicate. And this is something that we can all do to communicate better. Now, there's another thing called cognitive reserve. And some of my patients have heard of this, but some haven't. So when we think of the brain, we want it at its max strength, using all of its ability to help us communicate and get through stressful situations or communication opportunities. But if our cognitive reserve is lower, so our brain strength is already being taken up by other factors, we don't have much space left to communicate well. So doing lifestyle changes like sleeping and eating well, exercising regularly can all boost our brain health, so we have more of that cognitive reserve to communicate when it matters to us. And exercise is particularly important. We know that when we move and exercise, we're getting fresh oxygenated blood to our muscles, but we're also getting fresh oxygenated blood to the brain. We know that people who exercise more tend to have healthier brains, not just bodies. Other things are reducing stress and monitoring our mood, and we can work with our health team to address this, but also reducing isolation by connecting with others. I tell my patients that you should have at least one conversation with another person every single day, whether that's a neighbor on the street, someone working at a grocery store as we're checking out. Maybe when we're ordering food, we call and we talk to someone on the phone instead of just ordering online. We want to have opportunities to talk, to use our voice, and to connect with other people. And if we are starting to notice changes, we can plan ahead and practice for those social events that are really important to us. All right. And again, these are things that everyone should be doing, whether they have HD or not. So if we do have HD, it just means they're more important. Now, if you are a care partner or loved one of somebody who's living with HD, here's some strategies that you could implement. And the first one is asking permission. So if a person with HD is struggling to communicate, it's crucial that you acknowledge their competency. And that can be through things like saying, I know you know what you want to say. Do you want my help when the words aren't coming out? By saying this, you've acknowledged that you know this person with HD is still their intelligent self with ideas they need to express, and you've asked permission to help before you start guessing, right? And giving space to the person with HD to decide if they want to keep trying is also a good strategy. So you can ask them, is this something I need to know right now? Because we can keep trying together, or we can come back to this later, right? Both are okay. By saying something like this, you can reduce the stress of the situation, which in turn can help the person with HD communicate. And again, we're acknowledging that they are their own person who may or may not want help, or who may or may not want to talk about that thing right now. Oh, skipped a slide, I'll go back. Here's some other strategies. And this is communication burden. So communication burden is something I wish everyone knew more about. And the idea is that the way we talk can change the amount of work for the other person when they reply. So, for example, the way I ask a question can change how much work is required by you. If I were to say, "What do you want to drink?" I have now put all of the work on you to think about what options might be available, what are the names of those options, what do you actually prefer, what might the other person want you to say, right? You've given a lot of cognitive work to the other person without realizing it. I could instead say, "Would you like tea, coffee, or something else?" By changing my question, I've now made it so that the other person has less to think about. They know, oh, okay, so we're talking about tea and coffee, and I have the words to describe those, but there is space if I want to ask for something else too. I can reduce the burden on the other person even further by saying something like, "Would you like tea or would you like coffee?" Changing my question to a yes or no answer reduces the communication burden on the other person. All right. So when we're talking to somebody who's struggling to communicate, we can change our input of language to make it easier for them. Other things we can do are clearly establishing the topic and using real names. So before I switch conversation topics, I can give the person a heads up. Let's talk about where we want to go for lunch next. All right, I've set the scene. And then if I'm talking about a situation that happened in the past or in the future, I can use real names to help the other person know what I'm talking about. So instead of saying, "Oh, she called him," I could say, "Sarah called John." And suddenly I'm much more clear. All right. So again, these are strategies that we can do to communicate with other people to help reduce their communication burden. But of course, as a gentle reminder, communication for most interactions is about connection. So I want us to focus on the quality of communication. And we can think about what's the priorities of this interaction. Is this just us trying to bond? Or are we doing a communication exchange and there's crucial information I need to know right now? All right. Asking someone how their day was just to bond and build your relationship with them is very different from asking someone what their allergies are in the emergency room, right? So aiming for progress over perfection is important. And if things don't go as planned, just think about what small steps can you make to improve communication next time. Sometimes we might want to do things that don't even require communication, but allow for connection, right? So that can be sitting with someone, playing a board game, or doing something in silence that shows you're still there, but you don't need to communicate right now if it's challenging. Let's move on to swallowing next. I get a lot of questions about swallowing. So, why does swallowing matter? It seems like something we do all day, every day. Why do we need to talk about it? Well, it's important for a variety of reasons. It's for nutrition and hydration. It also allows us to take our medications and swallow away our saliva. It's important for comfort, independence, and connection, but safety. So when I talk about safety, a lot of people think about choking, which we call obstruction. So something obstructing the airway, we can't breathe. But there's also aspiration. Aspiration is when things fall into the lungs. Now, things can fall into the lungs in one big go through a big choking event, or we can aspirate small amounts of food, liquid, and saliva over time, and that can build up into a problem. So here I have some videos. I'm just going to pause them so we can watch them from the start. So this is an anatomical diagram of swallowing from the inside, again, so that you can see what's happening. And we're going to first look at the left video. So this is a person from their side. You see their teeth and their lips here, their nose here, their spine here, and their tongue, which a lot of people are surprised to learn is a lot bigger than we realize, here in the middle. So they're going to take some liquid in the mouth. It's showing up as white, and it's gone very quick. But lots of things had to move to make that happen. We'll watch it one more time. Gone. Now let's look to the right-hand side of our screen, and we're going to watch this video now. This is of a person who might have abnormal swallowing. So things aren't working the way they're supposed to. We see this person going to swallow, and it looks a lot different. All right. So you'll notice that instead of one swift motion, the liquid broke up. There's lots of bits of the liquid throughout the throat. Some of it's still in the mouth. And then some of it spills forward. And this is where I want to draw your attention. This part here is the entrance to the airway. This is our actual vocal folds that you see, that little gray line. What we want is for the liquid to go behind it, down to the esophagus, which is the tube leading to the stomach. But here we can see it spilled forward and went into the lungs. All right. Now I have some actual X-ray footage of patients with, again, a normal swallow on the left and an abnormal swallow on the right. And I'm showing this so you can get a sense of the difference. So we're going to look first to the left, that normal swallow. And here the liquid is going to show up as black. Okay. Oh, I skipped ahead. I wanted to play instead. There we go. Okay. So the person is going to go to swallow on the left. Gone. Quick. One swift motion, it looks like. And then let's draw our attention to the right. So this is another person swallowing, but it goes down the trachea, so the airway. So you see them take the liquid in, and do you see that black liquid? It's going back and forth and back and forth. Yeah. So the interesting thing about this video on the right is that it doesn't look like the person coughed. So when we're doing X-ray videos of swallows and somebody coughs, it looks quite chaotic on the film. The person's lurching forwards and backwards and their jaws opening while they're coughing, whereas this person was quite still. And I bring this up because sometimes when things go down the wrong way, we don't always feel it. And if we don't feel it, we might not be coughing. So just because swallowing looks okay from the outside, it doesn't mean that it's safe on the inside. Things can be going down to the lungs without us realizing, and we call that silent aspiration. Now, I have a big list here. Again, you don't need to memorize it. We can also talk about sending these slides out afterwards so you have all this written down, but here's some red flags to look out for, to know if you might be having difficulty swallowing. So that could be difficulty bringing food to the mouth or chewing, difficulty with feeling like the food gets left over in the mouth or feels stuck on the way down. Maybe we're coughing while we eat, or we have a wet and gurgly voice afterwards. All of these can be signs that things aren't working the way they're supposed to. Maybe it's more effort to eat, it takes longer, or we keep getting pneumonias. Now, the clinical or medical word for this is dysphagia. And again, this isn't a word you need to memorize, but dysphagia is just the term you might hear doctors and speech pathologists say to describe somebody who has changes in their swallowing. And there's lots of reasons we can have dysphagia, so there's also lots of treatments available. Now, before we get to treatment, we got to talk a little more about assessment. So if I'm a speech pathologist assessing somebody with HD and I want to see if their swallowing's okay, I might start off with something like a clinical swallow evaluation, also known as a bedside swallow screen. And this might just be a screen of watching them drink some water, getting a sense of how they're looking from the outside to see if there's red flags. But of course, the only way to know for certain that somebody is not silently aspirating is by looking on the inside. The main way that we do this for people with HD is through a video fluoroscopic swallow study, also known as a modified barium swallow study. And this is where we take somebody to the X-ray suite. The study itself takes about 30 minutes, and we take quick X-ray videos of them as they're swallowing different textures. Now, we saw a version of this earlier. That was the X-ray videos we were looking at. And these are great because they allow us as speech pathologists to see which muscles and which groups are implicated. Is there a certain anatomy not functioning the way it should? Is it a strength, coordination, or timing issue? And if that's the case, what options are available for the patient? Now, in other instances, another way we can look at swallowing from the inside is through something called a fiber optic endoscopic evaluation of swallowing, or FEES. Now, this one can be tricky because it's not usually advised for people who have uncontrollable extra movements. So if we're a person with HD and we have a lot of those extra movements, then this might not be a good idea, but in other instances it could be. So I'm bringing it up just so we're aware of it. Here, what we do is we take a camera on a teeny tiny little wire and we put it in the nose. We push it down to the top of the throat and it has a little light that shines so that we can see food and liquid going down from above. Now, maybe this can help us understand why it's harder to do this if we have a lot of extra movements, because moving around when we have a camera in our face isn't the most comfortable. So what about treatment? There's lots of ways we can look at it making somebody swallow safer. Maybe we have compensatory strategies, things like adjusting the texture of foods we have, or the way we eat, or the tools we use. Maybe there's rehabilitative strategies, so exercises we can do to improve the muscles for our swallowing. Or maybe there's other interventions. So maybe we need to look at things like medication adjustments, for example. Either way, we have to think about the goals. So typically we want to improve the safety of your swallow. So make sure as much goes down the right way as possible and as little goes down the wrong way as possible, but also improve efficiency and your enjoyment of meals while minimizing risk and making a plan for the future. So as things change, what can we do differently? So what can you start doing right away, whether you have a speech pathologist on your team or not? The first one is reducing distractions. All right, taking one bite at a time also helps. My trick is when you take a bite of food, put your knife and fork down on the plate and let go of them. Wait until you've finished swallowing. Maybe you need to swallow more than once to get it down, that's okay. And then once you've cleared the food or liquid, then you can pick up your knife and fork again. This is a very natural way to cue your body to slow down when you eat. And then also consider fluctuations. So if you have a general sense of when your HD symptoms are better and worse, maybe you can time meals around that. Or maybe you need to take multiple shorter meals just to ensure you still get the nutrition you need. We know that people with HD tend to burn through calories faster with extra movement, so we want to make sure you're still getting the nutrients. And then considering meal supervision if necessary. Now, a big thing that helps your health team is tracking symptoms. So this could be as simple as a journal or a calendar that you bring to your appointments where you write down what do you notice and what is difficult. Is it drinking liquids? Is it hard, small, solid food feeling stuck? When did it start and when is it worse or better? Maybe it's worse in the evening when we're fatigued, or maybe it's worse around lunchtime when we're stressed. And does anything seem to trigger it to make it better or worse? Who notices this? Is it something where you go, I actually feel okay, but my partner says I'm coughing a lot more than I used to when I eat, or vice versa? And then how is this important for your daily activities and quality of life? Now, one thing I find is that when my patients with HD are trying to get a referral to a speech pathologist, their doctors might say, oh, well, we don't have enough symptoms yet, or, oh, the wait lists are long. Now, a thing you can do to help is when you describe your issues, tie them to something in your life to show its importance. For example, instead of saying, I'm coughing more when I eat, we could say, I'm coughing more and it makes me nervous to eat, which makes me worry that I could lose more weight. for example. Or instead of saying, I'm slurring more when I talk, we could say, I'm having difficulty communicating and I'm worried that I won't be able to call for help in an emergency situation. Do you see how in both of those situations, I tied it to either a risk, a life event, or something important, just so that when I get that referral, they understand the importance, okay? Now, in most places in Canada, if you're looking at the public system, we use a triage system, meaning we get a variety of different referrals and we order them based on how severe the patient's symptoms are. So a patient who has lots of symptoms very urgently would be triaged higher than a patient who just has some vague symptoms. And that's why it's important to be specific when you're talking to your doctor, so tracking your symptoms can help with that. All right, another moment for audience participation. I've loved the participation so far, so let's keep it going. We're going to talk about aspiration pneumonia. All right, aspiration pneumonia, if you haven't heard of it before, it's a bacterial infection that can be common for people with HD. Some studies suggest that it can be a leading cause of hospitalization for people with HD. So it's important that we talk about it. Now, there's some risk factors for it, and I want to know, what do you think? What are the key risk factors that can put someone at risk for aspiration pneumonia? Is it 1, oral health, 2, swallowing health, 3, overall health, or 4, all of the above? And I'm going to go take a look at the chat and see what we've got here. Oh, good. Oh, people are already responding. Okay, it just took a moment on my end to show up. Yes. Yes, I see people saying all of the above. Great. And I love how some of you are just typing it if you're not using the poll. All of the above. Okay. And so let's break this down because a lot of people are surprised by this. So swallowing health, for most people, they can say, okay, I understand if I'm not swallowing well, things could be going into my lungs, increasing my risk for pneumonia. But overall health also matters. So if you have a strong immune system, you exercise regularly so your lungs get a good workout, then you're at a lower risk for getting that pneumonia because your body can fight off infections better. So swallow health and overall health. But the other thing is oral health. So the health of our mouth. Let's get into that because this is so important. We're almost at the end. So when we have things go down the wrong way, often they have bacteria from our mouth attached to them. And this is because when we're eating and drinking, it gets chewed and moved around in the mouth. Now, if that food or liquid or medication goes the wrong way, it's going to pull the bacteria from the mouth down to the lungs. And what the literature is showing is that it's actually mouth bacteria ending up in the lungs that's causing the infection, that aspiration pneumonia. Because of this, what we've discovered is people who brush their teeth well are at a significantly lower risk of getting a pneumonia, even if their swallowing isn't perfect. I have patients where we know because of imaging that bits of food and liquid, small little bits over time, do go down the wrong way to their lungs, but they don't get a pneumonia. And that's because they brush their teeth well, they exercise so their lungs are healthy, and they generally have a good immune system. Okay, so brushing our teeth should be considered a non-negotiable. All right, I have patients who, because they have issues swallowing, they just brush their teeth before every meal to make sure their mouth is clean before they start, so that if something goes down the wrong way, they know it's clean and their body's better at fighting it off. But of course, oral care can be hard for people with HD. We have extra movements, we have more anxiety, we have more difficulty sticking to a routine anyway because of the way HD changes our brain. So let's talk about that a little more too. When we think about oral care, it's not just for bacteria, it's also for saliva. And saliva is so important. It maintains the oral pH level It's also antiviral, antifungal, helps with tissue repair. Saliva can be considered part of our immune system. So, what are some things we can do? First one is visit your dental professional early and often. If you know that you have HD and that it can progress over time, then tell your dentist right away. For example, if you had plans for a major dental surgery in 5 years, but you just found out you have HD, you might want to talk to your dentist about getting that surgery sooner or changing the surgery or maybe doing something else because it can be harder for the dentist to do the surgery if we have extra movements. You can also ask about adaptive brushes and equipment, things like electric toothbrushes, water picks, those little handle flossers. Those can all help us keep our mouth clean when we have difficulty moving or we have a movement disorder. And then also, if we're having dry mouth or drooling, there are non-prescription products available. So especially with dry mouth, there's gums and chews and sprays and toothpastes and mouthwashes that we don't need a prescription for. We can get them from Shoppers, London Drugs, wherever you get your pharmacy needs, and that can make a big difference for some patients. So I know we're coming close to time, so don't worry, we've reached the end here for the content portion. Thank you so much for your attention.